medical sponsored webinar, which is going to be looking at modernizing third space procedures with adaptive multimodal energy. And the strap line is raising the bar, lowering the threshold. I can think of no better Thursday evening than talking for about an hour on third space procedures and in particular ESD. And then, of course, there's the football afterwards. So we've got a great Thursday evening in store for you. I'm Brian Saunders from St Mark's Hospital in London, and I'm joined by two of the masters of ESD and third space endoscopy, Adolfo Parablanco from Nottingham, who's going to be talking mainly about upper GI, and also Zach Teamoulos from Margate in Kent. And we're going to try and give you a sort of a real overview of how these new energies can be helpful in our endoscopic and in particular ESD practice. Next slide, please. So I guess the people who are in listening to this webinar, you're all thinking, you're interested in doing ESD, and what we want is we want technology that's going to be quicker and safer for our patients. In particular, when we're in the third space, we want to minimize those bleeding episodes which slow everything down. And we want to prevent any inadvertent muscle injury. And this, I think, in both of these two areas, this is a key area where the Creo technology is very impressive. And of course, we want it to be technically easier as well. ESD to have wide adoption and to really get the benefits of on-block resection, it needs to be something which can be done much more widely and be technically much easier. Next slide. So we're all familiar with the concept of monopolar devices. They've been around for over 50 years. Here we have a variety of different instruments that basically are generating energy at the tip of the instrument, directed across the patient towards a patient return plate to complete that circuit. So when we're using monopolar, we have to generate very high voltages at the point of contact on the bowel wall. And that can lead to issues with excessive energy and damage to that muscle layer. Next slide. So what about bipolar devices? Well, on the face of it, they do seem inherently safer. The bipolar instrument involves one electrode to another at the tip of the instrument. And you can see the Speedboat there with the upper active electrode and the return electrode very close together. So we're generating that heat at the point at the tip of the instrument, and we're using relatively low peak voltages when doing that, which perhaps can help to protect when combined with other modalities, which we'll mention in a minute, help to protect the muscle layer in particular. And of course, because it's bipolar, you don't need a return plate, and it's safe in patients with metal in the body, such as patients with pacemakers, brain stimulators, or any sort of metal implant. So there are a number of inherent advantages to bipolar. Next slide. What's very novel about the Creo technology is the super high frequency microwave coagulation. And many of you won't be as familiar with the concept of using microwave during flexible endoscopy. What microwaves are sort of part of the electromagnetic spectrum between radio waves and high frequency infrared. And when generated from the tip of the instrument, they cause the water molecules in the tissue to oscillate, and that means that there's a controlled increase in temperature with heat produced at the tip, which dissipates very rapidly from the tip. So you get this bubbling effect when using the Speedboat, which means that you get very localized heating, protecting deep penetration of heat, but still coagulating vessels. Next slide. And this is the original concept that we came up with back over 10 years ago. And the concept was to create a device which was multimodal and would do all of the functions of an ESD type or third space type procedure. Initially, it had an integrated injection needle. It had bipolar electrodes around the rim of the top of the Speedboat. giving lateral and forward dissection. There was microwave coagulation for the controlled hemostasis. And then underneath the lesion, underneath the speedboat, there was a protective hull, which was the plan was to reduce the risk of muscle damage with this. And of course, it could be rotated and orientated so that you could keep the muscle tangential to the field of dissection, particularly important when doing tunneling procedures. Next slide. The initial device was a little too large. So this is the current situation with the Speedboat UltraSlim and the Notch, which have been reduced in size considerably. They're now compatible with a larger range of colonoscopes and gastroscopes. There's a short version available, which has been optimized for the gastroscope. And you can see in the Notch, the design of the head of the speedboat has changed, giving you the ability to hook around vessels and into tissue, which I think does help with hemostasis and with cutting. The needle has been removed, but there's still an integrated lifting system with that channel at the bottom of the speedboat, which allows you to do high pressure if you want injection and irrigation. You've still got the protective hull and microwave and the bipolar cutting, and you can see the dimensions in the slide there. Next slide. And Creo are in the process of expanding their suite of tools which can be used with this new technology. And this is the SpydrBlade Flex, which is now available. It's a scissor type of device whereby you can grasp the tissue before applying cutting or coagulation energy. And it's extremely versatile. You can use it for cutting with an open blade, or you can use it for dissection or mucosal incision and for coagulation. And it still has the protective hull around the outside. So it's a combination of devices, and there are times when it's much easier to graft tissue rather than to have a needle knife type device. Next slide. So I'm going to pause there. I've given you a little introduction to the technology. We want to see the technology in action now. So before I hand over to Adolfo to tell us a bit about the use in upper GI, we're going to have a poll question, which I'd be grateful if you could answer. So let's have the first poll. So, what will drive the next major growth in third space endoscopy? Tick what you think your number one priority would be here. So I'm not sure. Is this going to give us a feedback as to how people are voting? Maybe not. Okay, so we'll perhaps come back to this once we've got your answers. Let's move on now. So, but a great pleasure to introduce Adolfo Parablanco from Nottingham. He is the organizer of the Nottingham course in therapeutic endoscopy. Here's our poll. So we've got better devices, 55%, more training pathways, AI assisted procedures, less so, improved reimbursement, that's important. But I think we're up there with better devices and more training pathways as the answer to your poll. So we've heard about the technology. Adolfo, let's see it in action. Over to you.
Thank you very much, Brian. Can you hear me well?
We can indeed.
Okay, very good. Thank you very much, Professor Saunders, for the kind introduction, and thank you to Creo for the invitation to the webinar. Just to say that very good course in Nottingham about upper GI endoscopy is organized by my colleague, Dr. Jacopo Ortiz, but I do have them sometime, not this year, though. So I want to show some cases about upper GI endoscopy with this new technology, Speedboat. Not much talking, mainly videos.
Adolfo, just before you start, can I just mention, I forgot to mention, we want your questions, which we'll take after Adolfo's presentation. So please put your questions in the Q&A, and we will endeavor to answer them. Adolfo.
Thank you. So just briefly, which are some of the limitations in my view for ESD in the upper GI tract? So I don't talk about duodenum because still is an area where we have to explore much more, and ESG don't recommend still doing ESD in the esophagus widely. But in the stomach, sometimes the locations are difficult. We need retroflexion. Access is difficult, as we'll see. And frequently there's fibrosis because of previous intervention, because of the type of lesions, and because the lesions can be ulcerated. And that's always a challenge for ESD because the difficulty cutting the fibrosis. The esophagus, which is a narrow lumen organ and where the wall is very thin, where we don't want to cause perforations. Frequently, more and more, we receive patients who have previous interventions, especially in ESD for Barrett's esophagus with previous radiofrequency, EMR, even ESD, and there's fibrosis and there's an increased risk of perforation, which is something that can be a dismal prognosis. Then we have cases for circumferential resections, which of course can be technically challenging and can lead to complications. And there's also a risk of stenosis with large resections. So this is my first case. This patient was 64 with diabetes and ischemic heart disease, quite common in the type of population we treat for ESD. The patient was referred with weight loss and vomiting, and an endoscopy identified an early gastric neoplasia with intramucosal neoplasia, at least in the biopsies, which was ulcerated. As you will see, this is a lesser curvature. It's a 2C plus 3, so depressed and ulcerated lesion. This is with white light. You can see the fibrin in the ulcer, and sorry. Well, trying to make the video. No, sorry. That's the white light.
Adolfo, just where are we here in the stomach? This is the.
So this is a lesser curvature.
Yeah.
So it's in retroflexion. This is narrow band imaging with the depressed lesion and ulcerated. This is with indigo carmine. And this is the marking with a monopolar device, which I started using in the beginning. And this is the circumferential incision in retroflexion with the monopolar device. This is already with oral traction, external traction. And now you can see in the video how there was significant fibrosis because the lesion was ulcerated. So we were expecting that. And access was not great. So we've done a circumferential incision. You can see the muscle, and we can see the bluish submucosa. I was using the IT knife where the tip is protected with a ceramic bowl, and I have used frequently in the past. But even with this device, you can see that there's some non-full thickness injury of the muscle. So I decided to apply a second traction. Now it's in forward view, and this is the clip band, the technique I developed, and this in forward view. Access is not great. It's more stable in retroflexion, but we want to have access to the lesion from both ends. So this is forward view. And now I decided to use the Speedboat notch to try and negotiate this fibrosis, because we have to understand exactly where to cut. So this is a Speedboat notch. This has a 1 millimeter tip. You can hook the tissue. You can inject. So we are gently, carefully rotating the device. You see the access is difficult. Sometimes the suction can help to get better access. But now I'm pushing the scope even more because it's forward view. We always try to do gastric lesions in retroflexion, but it's good to have access in both ways. So we gently cut a little bit, and then with a yellow pedal, and then inject, and then just trying to hook above the fibrosis with the tip of the notch. And as we cut a bit and inject a bit, and this is technique I learned to cut fibrosis, is cutting, injecting all the time. So we can try and identify where the fibrosis lies, and still, see, access, I didn't want to cut this, just want to show the difficulty. So when access is difficult, the risk of causing a tear perforation increases, but we persist. So we can, even with the tip is quite sharp and precise to cut shallowly. That's what we're trying to do, just to cut above the muscle. Okay, and we're trying to isolate the central fibrosis. So this is going, so I have to say that it took a bit more than 20 minutes from the moment I started using the Speedboat notch. The whole thing took 3 hours more or less. We can hook the mucosa back towards us. And
beautiful, beautiful, Dennis. Can I just ask you a few questions because
yes.
whilst it's fresh in our mind, I notice you're quite careful how you're orientating the speedboat there. Is that
Yes.
always parallel with the muscle?
Yes, so always trying to have the protective hull on the muscle, and especially you can have it a bit vertical, but never touching directly the muscle with the device. And it's very important that the nurses are trained for doing that. We treated the vessels on the post ESD ulcer, and this is the specimen. There's a tiny opening in the mucosa. I'm not sure when that happened, but it was removed uneventfully. And the lesion was diagnosed as a high-grade dysplasia, R0. So it was a curative resection. So it was a challenging case because of the fibrosis, but it went well, and I was very happy with the effect of the Speedboat notch. So this second case, was a challenging case, quite recent, quite young patient who had a T1B, so submucosally invasive squamous carcinoma in the esophagus, treated 4 years earlier, and had this esophagectomy, only left approximately 5 or 6 centimeters of the upper esophagus there. And on the follow-up, there was a recurrent dysplasia, which was removed in the other center where the patient was treated with an EMR, mucosectomy. And then the follow-up, there was multifocal dysplasia without any visible lesions, even on Lugol when they did it. So they referred the patient to us for consideration of ESD of a residual 5 centimeter esophagus after esophagectomy. So I was not very sure what we would be able to provide. This is just the cricopharynx, so it's the upper, just past the mouth. So this is the upper esophagus on white light. And at the bottom end, you can see the anastomosis. So you can see brownish tissue on NBI. This is a magnification showing B1 vessels, so no signs of SM invasion. This is Lugol. It's multifocal Lugol void areas. This is the upper esophagus just past cricopharynx. So we should do a circumferential ESD there with the limitations of previous EMR, esophagectomy. So this is the distal end. So we're going very close to the anastomosis. First we inject. So we do circumferential ESD following technique that we partially described with a double tunnel and the traction with a clip band line from the pillars. So that's the distal end. We're using a Speedboat notch as well. That's the only device I use for esophageal ESD. And we doing now the oral incision. This is with a trainee as well. We're doing together. This is the oral incision. We're making the first tunnel. Now we're using a conical cup. We can see the muscle on the right-hand side, and we very gently advance the Speedboat, avoiding, of course, touching the muscle with the device. We're reaching the end. That's a hole, but it's a good hole because it's the distal end opening of the first tunnel. We're opening the oral side of the second tunnel. We're going to leave 2 small bridges, and now we orientate the Speedboat again with the protective hull towards the muscle, which is on the left-hand side. And this is the distal opening. We can hook with the Speedboat again. And if we want, we can advance the scope through the tunnel. And we make sure that it is wide enough, as we can see now. That's the anastomosis. So now we only have left 2 pillars. And then we cut the mucosa of the first pillar, and we apply the clip line with clip band line. That's our modification. And then is when we apply the traction, still with the conical cap. And then we are cutting the pillar, the first pillar. And the Speedboat notch is very suited for this because we can cut vertically. We just make a small incision and inject. Incision, inject, moving parallel to the tunnel and away from the muscle layer. That's the distal end of the pillar. And of course, we coagulate the vessels whenever we find them, and we can hook the tissue. So we just have, after this, one pillar left. And this is the incision of the mucosa on the second pillar. Again, of course, there was fibrosis from that part was difficult from the EMR. And then we put a second traction from the pillar, and we inject, dissect carefully, creating like a stalk when we have this traction. Try to leave the stalk we are creating vertical. And we go with the speedboat notch. Orientation is extremely important for safety and efficiency of the cut. But even if it's a large resection with a circumferential ESD, it's technically not very difficult, I have to say. That's the end of the dissection of that almost. And this is the last few fibers. And we our nurse, even if the endoscopists could do as well, rotate the speedboat. And then we are just bringing out.
Adolfo, this is not your beginner's esophageal ESD, is it? This is very, very complicated.
Yeah, no, this is a tricky case. This is the remaining esophagus was denudated, so there's no mucosa left in the esophagus. We just come on and we have the mouth. And we coagulate the vessels. I don't show here, but we use the injection with triamcinolone to prevent stenosis, and we used Purastat as well. This is the cylinder of the esophagus. We can see the lugovoid lesions, and if we did a 4-week follow-up, patient is receiving oral budesonide and still healing. For the time being, no stenosis. The patient is managing well to eat. This is the fibrin. So that was a good case because the histology showed a high-grade dysplasia with some low-grade, and the whole lesion was removed. They said that the low-grade dysplasia was reaching the oral end, which I couldn't cut any higher because I would have gone to the mouth. But of course, we'll check the follow-up. That was a good case. I was quite happy with the result.
Beautiful case. What's remarkable there is that you don't appear to be getting much stenosis. Do you think that could be related to the advanced energy at all, or is that your triamcinolone?
Yeah. So we did a big study, what was communicating in the international meetings, and only the energy doesn't seem to be the only factor, but we do see that when in the peak model, when we use a bipolar energy with speedboat, the reepithelialization seems to be quicker or greater. But probably it's the full recipe. That's what we try to apply. But I do think it has to have a role, or we are investigating that, because when the cases we did and have been published with the monopolar, with or without the preventative measures, the risk of stenosis is greater. So I think it might have a role. Also, if the risk of touching the muscle or burning the muscle is less, we know that that's a risk factor also for development of stenosis. So we need to learn more. Probably not the only factor, but probably a significant one. Okay.
Two fantastic cases. I just want to drill down. When you're actually cutting the tissue, you've got direct contact with the speedboat at the tip. And this is something which is fundamentally different to using monopolar devices, where you can still cut the tissue or dissect the tissue without even the tip physically touching the submucosa or the mucosa. But here you've got to contact. Do you have any tips or tricks for how you orientate the speedboat to get the best cut?
Yeah. So I think as probably with the other devices, but certainly with speedboat, I always say that you have to work close to your target. So you need a good tip control, good access, and very good stability of the scope. I always show that I have a callus in my third finger in the left hand because of the pressure I put in the small wheel probably, and try to keep it fixed so that the tip doesn't move. So good access, stay close to your target. And of course, the manipulation of your assistant is very important so that you can, depends on whether you're using the notch or the Speedboat UltraSlim because they work differently, but you have to work close to your target. And if you have the notch, I think it's great because you can hook the tip. You can cut with the notch or you can cut with the side of the blade. And sometimes for fibrosis, the tip, the very tip, is very good to do a sharp but careful cut as well.
Mm.
Okay.
I notice you're using the notch mainly now. Is that right in upper GI, not the slim?
Yeah, only so for the esophagus, I only exclusively use the notch now because I think it's even safer. It's easier to manipulate. It's very good for a coagulation of the vessels, and particularly in the esophagus, you don't want to cause any perforations. I feel that Speedboat UltraSlim is very good. Speedboat Notch, I think, is the best one for the esophagus. I only use that one, and especially if there's fibrosis, which sometimes you cannot predict. Sometimes there's some muscle retraction, even the esophagus fibrosis. I think you have to be ready with your best tool. So that's what I do. Yeah.
And nowadays with the speedboat and the microwave, I mean you're having to transect some fairly significant submucosal vessels to resect a lesion like that. How many times are you needing to resort to coagulation forceps, or are you able to control virtually everything now with the microwave?
Yeah. So now the last time I used it for the esophagus was a patient with varices, large varices, where I was very happy that it was going very, very good with the speedboat. However, inadvertently, I cut one of the varices. And then I just went quickly for the coagulation forceps because the bleed was very, very important. Apart from that, in the first case, when we were getting used to the speedboat in the esophagus, in a few cases, the last 10 cases, we used, I think, 3 times a coagulation forceps. But we've done more than 100 cases now for upper GI, and we never use it. So there are tips as well. You have to keep the field dry. Well, it's something that you can do. And I feel very comfortable with the speedboat because of the microwave is extremely safe.
I'd agree with that. I mean, because it's a new technology, it takes a little bit of getting used to the concept of using microwave. How many bursts of 10 seconds? Because it's the generator cuts out after 10 seconds, gives you a pause. How many bursts in the same place of 10 seconds would you be happy doing in the esophagus?
Yeah. So now with new ultra slim and the notes, we only give 5. But and that's I think it's a very important, a good, very good question, important feature. Say that if you are cutting and use if this for the treatment of bleeding, then I treat usually twice, so 2 pulses. It's not completely blindly, but when you see the blood, just press the blue pedal. You don't need to be extremely precise to see the bleed inside because it's very safe and you can make it stop. If after the second pulse it's still bleeding, then I go, I push, I collapse the side with the cap. I fill it with water, keep on flushing water or saline, and then I pull the scope back slowly, see how the bleeding happens, and then I direct the tip there, and then it stops. But if it's for prevention of bleeding, as many times as needed. So of course it's more in the rectum, but in the esophagus, I can use it up to, let's say, maybe 4 pulses. Usually 1 or 2 is enough, but I feel
And
comfortable
obviously,
using.
the worry with the coag with other sort of monopolar hemostatic forceps is if you keep applying it, eventually you might cause a perforation or a delayed perforation. I've not experienced that with the microwave. Have you?
I've had a perforation in a relatively small pig, in a study we were doing. That's the only perforation I had with a microwave. And no patients.
No.
We've done in upper or lower GI. So I show a case later with perforation.
Okay.
The
We
only
got it.
one we had in upper GI, and we've been using the microwave. Even the perforation was there. I'll show you. Of
Adolfo, we've got some questions coming through, so I think you should take them now.
course.
So can you, there's a question from Andy Bell saying, can you share when you tend to add traction as a rule of thumb? So we'll start with the stomach. When do you use traction in the stomach?
Yeah. So I don't know if they said I designed and invented the clip band method or use of orthodontic bands for the GI tract. So it started using them in the stomach and it tried them in pigs, as published in GI Endoscopy 2011. So in the stomach, I use in the cardia or lesser curvature, usually it's a clip band line. So I make the knot in the band and then clamp the band with a clip and external traction. In the other locations, I try to use the clip band, so 2 clips and 1 band, sometimes a longer band. In the esophagus, always, always,
Always.
always, always,
Mm.
with external traction, always. Because it's shown in different studies, in RCTs, in meta-analysis, that it reduces the time, it's safer also for trainees, and always, always.
I was watching you in that gastric case, and I was thinking I was so jealous of the amount of space you had in the stomach compared to the colon,
Mm.
where that's a real issue. But I think you demonstrated beautifully how traction can really facilitate this, and you know thinking about traction in different modalities and in different directions. Would you use more than one clip band at all during a resection, or is that too much?
In the stomach. Yeah.
Yeah,
So it's, I mean, once you start using it, there are many modifications you can make. If for a small lesion, one is usually enough. For bigger lesions, you can have multiple. Yes. And you can, in that case, I combined, you can use in retroflexion and forward view, both of them. And you can use clip band or clip band plus clip line. Case I showed, it was external and internal. So for bigger lesions, and you can change them as you progress in the ESD, because in the beginning, maybe you want one side, and later on, maybe you want the traction from a different side. So, and I think there's a learning curve. If you don't use it regularly, then you won't be ready to use it when you really need it, as
right,
happens with everything. So I tend to use it a lot.
right. And there's a question about notch in retroflexion. Does the notch work well in retroflexion?
Not yet, yeah. So I don't. It works in retroflexion. Yes, it does. In fact, in the beginning, I didn't use the speedboat much in the stomach because I thought that it wouldn't work well in retroflexion, but I noticed it does. And I use a 2.8 channel. But it's good to safely do it for the device and for the scope, as happens with other devices, to make the scope straight, advance the speedboat out a little bit, place it in the rotation you wish, and then pull it back just to the tip of the scope and retroflex. Then you have it, rather than forcing the rotation in retroflexion. Okay, but even when you are retroflexed, you can try and slightly rotate, but I think it's better to make it straight and rotate a bit more, and then retroflexion again. So it does work there.
Okay, great. And so
Okay.
just to sum up, in the stomach and in the esophagus, how does the advanced energy really change your ability, your approach in
Yeah.
resection?
Yeah. So I still have one more case for Barrett's,
Okay,
but
okay.
if you want, I can show that one first. But I for the esophagus,
Let's see the Barrett's
yeah.
quickly. Let's
And
see
so
the
yeah,
Barrett's,
okay.
and then
So
we'll ask you that
okay.
question. Then we'll move on
Okay.
to the colon.
Thank
If
you.
that's
So
yeah.
yeah. So this a lady in her 60s, long Barrett's. Also in another center, the patient had a piecemeal EMR for a visible lesion with high-grade dysplasia, was referred for radiofrequency. So they noted that my colleagues doing the radiofrequency, there was a stenosis, so it required dilatation. So once it was dilated, they found another lesion adjacent to the previous EMR. And then that was a cancer. So I did an ESD with a lot of fibrosis already, but this is not the case I'm showing you. In the follow-up, 1 year later, there were 3 lesions noted on acetic acid. One of them had high-grade dysplasia, and that esophagus had been touched already with EMR, with dilatation, also a lot of fibrosis, with an ESD. So they discussed to do radiofrequency, which didn't seem to be a good idea because it was narrow. Surgery, which is always something to take into account, or circumferential ESD. And that's what they decided together with the patient. So we tried hard. And I'm trying to advance this one. No. So we do the method described that I showed you earlier. So this We marked, there was a distal part which was circumferential, more or less 5 centimeters, and the oral side, which had large tongues. So it's a shorter video because the technique is similar to the circumferential one I showed you earlier. This is a final step where you can see how the hooking with the notch is very nice. So the defect was in total 14 centimeters. 14. Half of it more or less was circumferential. The proximal half was 50% or a bit more. So we retrieved the specimen. A lot of fibrosis with all the interventions. And this one took almost 5 hours. But can be organ sparing. Otherwise, it would have been for surgery. And we inject triamcinolone again. And we apply the first that we could expect stenosis here because there was a stenosis before. So, and there was stenosis in the follow-up. This had a multifocal low-grade dysplasia, high-grade dysplasia, nothing left on the histology. So the specimen, that's unstretched. But I said the ulcer was almost 14 centimeters. So it was a long one. I was quite pleased in the patient. And
Fantastic.
mm,
How much
and
triamcinolone are you injecting there?
we
You're
inject
putting
yeah,
tiny amounts sort of circumferentially around at different
mm,
levels.
yeah, per centimeter of defect, 10 milligrams
Okay.
quadrant. So it's a 40 milligrams the ampule, so usually no more than 120, 1 to 3 ampules diluted in normal saline. So at 4 weeks, there was not very long stenosis. It was mainly the distal end, which was circumferential. So it's been dilated already 4 times, but it's a relatively short stenosis. And we could expect, as I say, with all the interventions the patient had, but it was a curative resection. So let's hope that will be enough for this patient. So it's a good thing. And this is, I like to share the complications because I think it's where we learn more. So this was done by the fellow, but I was supervising. So the failure was particularly for me because I was supervising. This is our only perforation in the upper GI tract. As I said, sorry. Sorry, I want to make the video run.
I think you need to go back one.
Yeah, but now this maybe the internet is a bit I think it's a good case. I'll go a bit quicker with this one in the interest of time, but I think it's a good case to see.
Question for you.
Yeah,
What criteria do you use to scope patients early post-esophageal resection? For a big resection like this, when do you go
yeah,
back in? What's your
yes,
the order of events?
yes. I'll tell you right now, Brian, only because if I stop, it might not be
Yeah,
able
yeah,
to
keep going,
get.
keep going,
So
keep
this
going.
injection was full thickness in retrospect. You see, the lifting is poor.
Yeah,
The problem.
it's in
We
the
have
wrong
already,
plane.
this is
Yeah.
a patient with Barrett's after radiofrequency. And then what happened that, and now you see, this is the UltraSlim. After each cut, I like to inject, but it was 2 cuts, and you see one more cut with no injection. So it was a poor injection technique and 3 cuts without injecting. So even with the Speedboat, of course, the perforation can happen. And now the incision is complete. You see a bit later that when the injection happens in the right place, there's a nice lifting now. So when the injection is in the right layer, it does lift up. And then there was a tiny perforation. Let me show it. Because if I move it, I may not be able to go back. So we complete the incision there. And on the way back, doing some trimming and treating the vessels, there was bleeding. So that was the site where the problem happened. There's bleeding, and we are microwaving. Microwaving, it looks maybe a bit deep, but so we treat it, even if it's not completely wet. Well, now it's a bit slow. So we microwave the site, and we treat the 2 pulses. there was a perforation there, but certainly not from the microwave. I think it was already there because of the issues I told you. Now, this is running a bit slower. I hope you can see it, but at least I will not show the clipping was very simple because the perforation is small, but you'll see it now after we stop the bleed. You see the perforation is almost pinpoint. So it was treated easily with 2 clips, but basic technique is very important, of course. If the basics don't work, then you can have the complications, okay? Just let me show you at least stopping the bleeding because the video is running a bit slow now, and it might look that it takes longer, but it was simple. So if there's some fluid around, you just need to insufflate. Try to insufflate. You can tilt the head up or down or sideways if needed as well.
You
So,
saw the bubbling there, didn't you? That when you
yeah,
get that bubbling, you know that
yeah.
you're starting to win with the coagulation.
But you can see the third space there at the bottom. Okay.
Yeah.
So,
Yeah.
and then it was clipped nicely.
Yeah.
So that was the last video. So just to summarize, I feel that Speedboat, this advanced energy for upper GI tract and very especially for the esophagus is safe even for training. This was one perforation out of more than 100, where almost in half of them the training was participating. Quite advanced training, I have to say. You don't need to change the settings. That's, I think, is very, very important and practical. You don't need to exchange devices, no need to use an injection needle in between almost. It's very versatile. You can use it in forward view and in retroflexion, knowing how to use it. Microwave, I feel it's extremely effective and very safe to pre-coagulate the vessels and also for the treatment of bleeding. As I say, when you see blood, just press the blue pedal with 2 pulses, even if you cannot see the bleeding side very clearly, because it is safe and it will stop the bleeding in most of the cases. We reduce the amount of energy delivered and the protective hull naturally facilitates the tunneling.
Fantastic.
Thank you very much. Thank you very
What
much.
some really fantastic cases there. Just very quickly, tell me about when you would think it's safe to follow up and dilate somebody after a big endoscopic resection like that.
Yeah, so we bring and you asked about the follow-up. So for circumferential resections, or at least over 75% of the circumference, where you know the risk of stenosis increases, we bring the patient after 3 weeks.
3 weeks, and
3
that's
or
you think
4,
it's safe then?
yeah. We contact them, see how they're doing, but yeah, because if
Yeah,
we find the stenosis there, the sooner the better. And then every 3 weeks, more or less, we bring them again and follow them up. But follow up depends if the resection has been complete and curative. After 3 months, we bring the patient again for a endoscopic follow up.
fantastic. Well, that's been a great set of cases using the. We've got to get on now to the most important organ in the body, which of course is the colon. So hopefully, Zach, are you there? That's the question. Is Zach around?
Yes, I'm here.
Oh, Zach, fantastic. Well, it's a huge pleasure to introduce Zach Teomoulos from Kent. I think nobody's done more speedboat cases than you, probably in the world, and you've got a vast experience. So we really want to see some just the nuggets now of how to get the best out of the device, how to really do it safely and effectively. So Zach, we hopefully have at least 5 minutes for questions at the end. Over to you.
Hi, Brian. Adolfo, it's a great privilege to be with my supervisor and all these years, a great friend, Brian, and also one of my new mentors, Brian, Adolfo, who helped me to augment my learning curve on the upper GI too.
Whilst you're doing that, I'm going to fire a few
Please do,
questions
please
at
do.
you. So, notch or slim?
I can tell you 100% notch. I have changed my practice remarkably too from the ultra slim to notch. But for difficult cases, I can really show you some really cases where I push the boundaries and trying to see the fantastic outcomes even on the esophageal like Speedboat POEM or Z POEM. Which I have to say during all this years, the last 3 years with my mentor Eduardo Albanese and Adolfo, I have managed to move faster to the upper GI by using the UltraSlim and the notch. We did our first study, as Brian mentioned, the first consecutive patients where we found out that the first speedboat, was about to increase the speed of the procedure. So about 70% of the duration, 30% of the speed was actually linked to the lesion surface and fibrosis, which is, we believe, are strongly based on the ergonomics and the design, favoring the tunneling technique that Adolfo mentioned. Actually, this can be also implemented to the lower GI. We using the notch actually was really here we go. Here we go. Can you see on my screen now?
Yeah, we got it. Yeah.
Okay, so I'll just pass a few slides. This is actually the study that I was trying to tell you is now in the process of publication, and we managed to publish a few cases of patients that have been. This is used with the initial speedboat device. With the injector, what you can see was covering the entire almost sigmoid circumferential area. By using the speedboat inject, we managed to defer the patient from surgery to endoscopic surgery. And as Adolfo alluded, we waited for a couple of years, and here we go. We got a kind of scar, which is very, very smooth. Very, very smooth epithelialization. I don't know why, Brian. Is that the advanced bipolar energy? Is it the maintenance of the stem cells in the deep submucosa? We don't know exactly. See, there's no really scar. It's a really smooth reepithelialization after almost 2 years. And then, by using this kind of technique, we can definitely, push the boundaries. We could perform different layer separation by using the UltraSlim. The UltraSlim, it's definitely the new iteration, gave us more tools during our endoscopic surgery. So we could manage lesions of this side close to the anal sphincter, for example, where you can see there was a recurrent cancer, post chemo and radiotherapy. And we managed to separate every layer, submucosa, intramuscular, full thickness, and try to remove the lesion in one piece. It's the way that this is under retroflexion, as you mentioned, Brian. Yes, we can use UltraSlim under retroflexion very successfully, but you have to be very careful with your tip control. And at the end, we could manage to get to the puborectalis link, which is the fourth space, mesorectum. And when you mess up with the mesorectum, you have to be ready and behave like a surgeon, because what can happen? This can happen. You can hit a big mesorectal arterial, and this arterial, can be really. This is an unedited video. It took us exactly 1 minute and 18 seconds. We managed to we kept our breath. We managed to find the spurting arterial within the mesorectum, and using the ergonomic and using the dimensions of the device, we managed to tamponate. So I think tamponate is one of the key things, apart from having a dry field. Tamponate the vessel. It will give you the time and the space to rotate, to change the angulation, to improve the power density between the vessel and the microwave. As you can see, in 10 seconds, we managed to stop the bleeding of a mesorectal arterial. It was quite scary, I would say, but that was very successful. So you can see here the different level of separation of intramuscular, submucosal, full thickness, very close on the anal sphincter, and trying to retain anticipate any incontinence in the future. Now you can see under retroflexion, you see this circular muscle layer is a part of the puborectalis link, which actually sustains the rectum in one space. And then we can do other stuff. We can do even a recurrent malignant lesions actually in the anastomosis. I mean, I never thought that I would be able to operate on an anastomotic on colonic anastomosis. So this kind of advanced bipolar and the precision, the control, the precision, we could remove the clips. So we managed to remove surgical clips and try to isolate the recurrent malignancy within the anastomosis successfully. Again, without any kind of, I would say, fear, but you know exactly how. So I think this endosurgical tool, it really gives to our hands more potential to invade the third or even the fourth space. And Brian mentioned that very nicely, and some graphs. I just want to bring this to the attention to the attendees. This is now the notch. It gives you exactly what we need. We need dimensions. We have 1 millimeter, which is more proximal to the notch, and then 1 millimeter is the notch. So it's in total, if you keep your eyes to the notch, you don't have to worry at all because you have an optimal cutting as well as an optimal coagulation. Again, now lately we do have microwave only for 5 seconds, not for 10 seconds, which is great. And you can go on any direction. Even you can hook, we can pull, you can cut. So really, the notch gives a different kind of perspective to our dissections. And this is a very nice sickle SESD that we managed to use for the first time the nodes. There was a bit of submucosal fibrosis, and as you can see, the main thing that everybody is worrying about is the depth of the penetration, and that's why by using the nodes, we just completely forget the rest of the shaft. You just keep your eyes on the nodes. You can cut even blindly, I would say here, because you're exactly 1 millimeter. You have a very good lift, and then you can target, you can hook, and you can dissect, and you can go blindly in between vessels. I always go blindly, Adolfo. I always go a bit 1, 2, 3. The third cut, I always go pre-coagulation. I coagulate for 5 seconds, save so much time instead of hitting the vessel and have a readout. And then on the same lesion, as you can see, you can seal, you can operate on a very, very tiny space within the cecum. There's a fibrosis, and within this fibrotic element bundle, you can see and more than 1 millimeter vessel. And now you tell me, how can you measure this 1 millimeter vessel? Yes, with the knots we can measure. If the vessel can fit within the knots, is 1 millimeter. If it's more, if you cannot fit within the knots, is not 1 millimeter. So that's again for the first time something to measure and have this in mind. And also, I always, always, even to my trainees, I always advocate to inject just prior to the dissection, because that injection that gives this immersion effect and really gives this milliseconds before you apply the bipolar adaptive precise cut. And I think that gives you a lot of confidence. Now, somebody could argue, say, can the knots cut under water or under saline? I think by using the mechanical force, you really eliminate all the water. So yes, you can use the knots under saline, but you have to be very, very, very careful how you apply the forces. And then what I found, I mean, with the knots, I have really managed to move forward. I've been always doing some proximal colonic lesions, but with the knots, the speed is absolutely amazing. It's 20 square centimeters per hour, almost on any lesion we do beyond the splenic fracture. So it's definitely helpful. The knots gives me the confidence to embrace the vessel, and then you need less bursts of microwave. Because if you think about geometry, you have also microwave not only oral side, but also on the anal side. So these two like of embracing gives microwave both sides at the same time, embracing the vessel. And this is the result, a lesion, 5x4 in 35 minutes with great speed. And of course, you see no carbonization and no damage to the tissue. Now, I have to show these things, and these are real stuff. Brian has seen all my, Brian is as my mentor. I always give him a report. Whenever I do something, I text him something. We always celebrate with the notes. I apologize. We always celebrate with the music. So this is the latest rectal T1 cancer. That was done in 3 hours. It was 18 by 11. Can you see the speed? It's 51 square centimeters per hour. The patient went home. It was an hour-zero resection. So these are the things that I think people, they can really test their abilities, but you need to have the right tools. We haven't used CoreGrasp or any hemostatic monopolar devices for 7 years now. I never had any viruses actually, but definitely I can tell you big lesion, big vessels, penetrating, feeding vessels that can easily treated, but you have to be keep in mind dry field, use the cup, tamponade, use all the good parts. That's also with the Speedboat we can do intramuscular dissections very successfully. Again, this lack of carbonization, this allows you to see the intermuscular plane clearly. With the injection you can do between the two muscle layers, you can really aim for the top, for the inner muscle layer, and you can cut really slickly, very, very slicky. And then you can see, we can do some follow-ups, which actually they're very. Then we have other lesions, which actually in the sigmoid, this lesion, for example, this is personally one of the largest in the sigmoid. It's 15 by 11 in 5 hours. Yes, the speed was 25 square centimeters. As you can see, that patient is young, 44 years old, with 48 BMI. So nobody wanted to give actually a kind of surgery. But again, we are lacking of post-polypectomy. Nothing was mentioned about that. We have less than 2% of post-polypectomy bleed. So, having all this kind of good outcomes. I mean, you make your managers to look slightly, intimidated, but this is the reality. And then the more we do, the more we realize that it is definitely there's no limitation. You can perform a hepatic flexure lesion very safely in a timely manner over a fold. I found very interesting, which has not been reported yet, the straddling fibrosis, which always over a fold, and it has not been described by even by Japanese experts. When you cross the fold, you can always have a bit of fibrosis because of the friction. I don't know what's the reason, but definitely, with the knots, you can overcome all this kind of difficulties. And then you can move to the setting colon. You see on the back side, you can see the ileocecal valve. Lesions like in 90 minutes, 9 by 7. The main concern there was not to remove the lesion, but just how to extract the lesion from the rectum. So, what's really, I was trained by Professor Saunders on EMR expertise, and now I'm really not. I don't feel so much confident performing EMR. And the only reason it's not that we're not good. It's about the delayed complications. You have a big lesion like this on a EMR defect. You always worry about the post-polypectomy bleed and a bit of post-polypectomy syndrome, but mainly is the bleed. So these are the things that I think you need to have, of course, the right setup, all right? But I think the more the notch actually gives this kind of opportunity. And then you go to the cecum. So I just try to give you on every segment these are the last year cases. You're using also the dialumen, which is very helpful, I think. Adolfo, you're very familiar with that. And you can see operated very close to the appendiceal orifice. That's something, it's very scary, but you can see, I just want to take your eyeballs and you can see there's no carbonization within the sickle pole. There's no thermal injury, and the patients are completely free with a very uneventful recovery. I think all these are things that I think it can be done with the colonic. But I have to say, in 2 years' time, I moved to the POEM. There was a study that was done recently that proved that there's a non-inferiority between monopolar and bipolar, between Speedboat and monopolar devices, and we found that definitely there was we can perform the entire lesion, the entire process within one device. And there's some very nice examples during the Speedboat POEM. You can see the notch. The notch is embracing the feeding vessel, which is, if blades, it makes a big mess and you lose your views and you lose your orientation between mucosa and muscle layer. You just apply 2 sets of 5 seconds, and you can see you have very clear margins. The delineation of the muscle layer and the mucosa on the Speedboat is so important. It is really imperative to be aware. And when you get to the geojunction, I mean, the bipolar adaptive energy, it can do a full thickness dissection. You can see well on the geo junction here using the UltraSlim on the right hand side, and then you can see how you can easily do really how slick, how it cuts like a like a scissors. And then if you have really fibrotic geo junction post Heller or door, still with a notch, you can dissect it, you can separate the layers, either in the colon or in the esophagus or in the and this is actually on a courtesy from Eduardo Albanese, which is actually I've done some cases with SpydrBlade that Brian mentioned earlier. This scissor-like type is really very useful. I found for specifically for the Z poem, it really makes a huge difference. It's quick, you make first the mucosal incision very easily, and then using the scissor-like type to cut the septum initially, very direct to the septum, and then you go to the other esophageal muscle fibers. You can see how easily you can first coagulate and then you can cut. So that gives you this confidence to avoid any kind of bleeding. I think these are the things that really helped me massively to move to the upper GI and the knots. I've done recently cases on the gastric cases, Brian, 7x5. I think the knots definitely can retroflex. Definitely, it can be on the hands of, I would say, non-experienced operator. Very, very safe, and it gives you very good outcomes. And the last thing, sorry.
Yeah, go on. You finished, but we want to ask a few questions because we're running
Yes.
out of time.
Yeah, and the last thing is, you do the mucosectomy very easily, and then you close that. I think that's the last slide actually. So my last slide conclusion is I think the Speedboat is with a notch version. I think it's safer. It's definitely more precise bipolar cutting because it's been augmented by retraction and hooking. I think immersion cutting helps you to override this kind of fibrotic segments. You definitely have a better control and targeted microwave coagulation by embracing the vessel. And you can, anybody, can really test themselves with more challenging cases. And the last one, if you want more information, you see this lovely esteemed colleagues of mine, Professor Saunders and Professor Parablanco. They're going to come in Athens, and we're going to have very fun using the notch, the UltraSlim, and any other kind of new advanced technologies. Thank you very much.
Thanks a lot, Zach. I mean, you've shown some incredibly complicated cases there, and that's a condensation of huge experience and skill on show. I want to sort of just end the seminar by talking about the delegates there. They're thinking about getting more involved with doing ESD. You hinted that actually perhaps very soon we'll be doing everything on block, everything by ESD in the colon. Let's say, is this how do you start your ESD journey?
I think you are the best person to to answer the question, Brian. I think I think for me the most important thing is to have a tip control. So whatever that means, it means that you perform an easy EMR, a complex EMR, a cold snare EMR, anything that can really improve your tip control. Then the second is actually to be able to attend cases and get a mentality uh, from experts, from videos, from courses, and then you have decided that you have to commit yourself. I don't think that anybody that will won't commit themselves to this kind of because it's a sometimes very tedious, it's sometimes time consuming. You have to have a dedicated team that will support you. There are so many times I wanted to really abandon, and my team, my nurses will say, no, we have to finish off. So if you create this kind of need and the kind of mentality around the team, I think you have only successful cases. Regardless the sign, the size, I think and of course at the end you need to have the right tools. Yeah, I mean all this, it's a kind of a process, a kind of cascade of events that you have to commit yourself. I think commitment is one of the most important things, and it doesn't matter if you use monopolar or bipolar. I think everybody will find their own way at the end, but by default, bipolar is safer, and microwave is more control. Is Today I had a very big case. Imagine I couldn't put the notch. It was two times the notch. It was 2 millimeters, and out of the five of these big feeding vessels, I managed to control three with a precoagulation. The other two, I managed to cut after third burst of microwave. It was a mess, but I managed to control my my stress. I managed to tamponate. I managed to stop the bleeding. I managed to use the flag sign. Where's the bleeding vessel? I cleaned my field of view and applied the microwave successfully. So it's a matter of how much you want to invest on this kind of project.
Two quick questions. I mean, one is, I noticed, and it's great watching you, who is the person who's used these devices more than anybody else in the world, and is the master of them. How when you were using the microwave coagulation on that very big bleed in the lower rectum, you were slightly rotating the device as you were applying the microwave. What's the rationale there?
First of all, it's a desperation, Brian, because I couldn't see where's the bleeding vessel. So I was trying to rotate because I was trying to um, tamponate the vessel without looking. So that's why you see the main. When we learn with the monopolar hemostatic forceps, we learn that if we hit the vessel, change the device, get the forceps down to control the bleeding. With a microwave, it's exactly the opposite. You do not move. If you hit a vessel, you do not move. You just stay on the same place, try to move a bit of the sides, rotate the device to tamponate. Because if you tamponate, automatically you've done half of the job. The other half of the job is going just to apply, dry the field, the cap, and then apply the microwave. So it's completely different mentality, and I think that's why people they have to understand. If they want to go through this journey, they have to change mentality. Otherwise, replacing a device, I think that's the not the appropriate thing to do, according to my opinion.
I mean, most people are still doing EMR, piecemeal EMR in the proximal colon, and even though that's usually quite successful, and we've got the recurrence rate down by doing, good quality piecemeal EMR, there is always, as you alluded to, this horrible day 3, day 5 delayed bleed risk. And no matter what you do, it seems to be that risk. Are you implying, do you think that by using the advanced technology, you're coagulating the vessels and you're effectively eliminating that delayed bleed? That's because that would be a major step forward if that was the case.
You mean with a microwave with a different tool? You mean not with a speedboat because it's not doesn't make any sense to do an EMR and then apply microwave.
No. What I mean was, if you rather than doing piecemeal EMR, if you do ESD using the speedboat and you're cutting the vessels, you're coagulating the vessels,
Yeah.
does that effectively eliminate the delayed bleed risk?
To my series brand, I have never. Very rarely I manage to suture the defect. The resection base. One, it's very big. Number two, I don't have access to the suturing devices, the very complex ones. So I rely only on meticulous coagulation with microwave all the vessels,
Mm,
and then try to use another kind of spray or pure or other gels, pure that can might prevent. But absolutely, I think I learned from you specifically when we finish any kind of resection, we need to spend at least half an hour, at least to see the margins, to check the vessels, and that I think makes a huge difference because then you will regret it. If you don't do that, even with any ESD or SSD, you'll have some delayed bleed. So I
mm,
think it takes time, but microwave, it's so safe.
mm,
Because when you place the hull onto the muscle layer, because you've done a very deep dissection, it doesn't cause any delayed
mm.
perforation or bleed as far as I'm concerned.
The cases you showed with the completely clean muscle layer and a little bit of submucosa, there was no charring, there was no injury to the muscle, which is quite remarkable with lesions of that size.
Again, it helps with the ergonomics. It helps with the adaptive bipolar energy. Is how, as Adolfo was trying to mention, how you place the device. That's why it's very dynamic. You have to always change the position of the device to follow the contour of the bowel. Try to go slowly. Sometimes the slower you go, the faster you finish. These are some very simple advices that people forget because you get very excited, and it's good to be excited. But
Mm,
when you get excited, then that's why you have the complications or you become tired. And
mm,
that's why I think again, as a team, you have to discuss all your cases, as you know very well. We have started this MDM many years ago, thoroughly to have planned in advance anything, any accessory you want, and anything that you need at that time, it should be planned ahead. Otherwise, you'll end up with some very bad experience, and I think that's possibly will be your last
Yeah.
experience on this third space.
Zach, you've done brilliantly there. We've gone over time. I'm going to give Adolfo 30 seconds just to sum up what he thinks the advantages are of the advanced energy in the upper GI tract specifically. And any final thoughts, Adolfo?
Yeah. So just in 5 seconds, something important as well to develop ESD is to be very, very interested in early diagnosis, not just therapy, and go with somebody who's passionate, because you have to be passionate, as Zach said. And advantages, as I tried to show earlier, is that you don't have to exchange devices. It's quicker. It feels, particularly to me, it feels extremely safe compared to monopore, extremely safe. And I always think, what is better, bipolar effect and the cutting very sharply, or the microwave, because both features are great, and I think combined they make an ideal device. So safety, probably less delayed complications, and also to me very important that I feel much more comfortable when I have to train somebody and they're using this device compared to a monopolar device, where you can use the energy even without touching the tissue, as you said, means that it's less controlled to me and probably more aggressive. So
It's less stressful for the trainer as well, because there's perhaps a fraction more margin for error as well on the muscle. Zach, any last thoughts?
I think yes, I think that kind of technology has definitely changed my life in terms of the safety. I am a true believer on anything that can be really make a safe dissection. I think advanced bipolar energy can deliver that. And I think my advice to anyone who wants to really, they have to commit themselves and they have to stick to one kind of technology. They cannot just move around to monopolar, bipolar. It's completely different mentalities. You have to choose what is best for you, and I think best for me at least is this type of technology.
Well, I think we're well over time, so we're going to have to wind it up there. I've learned a lot. I've thoroughly enjoyed hearing from Adolfo and Zach, and both of you. Thank you so much for sharing your cases with us. We've learned a huge amount. Hopefully, you, the listeners on the call, have also enjoyed it, and I'm sure you're going to enjoy a long career of polypectomies and resections moving forward. It's certainly the way that the things are going. We're going to be eventually doing everything on block, I think, and not sending to histopathology in separate pieces. But you need the skill, you need the technology. We need to think about training seriously, about how we're going to restructure training to give people the opportunity to do this. And then once they are trained, also give them the volume of cases to maintain their skills within appropriate environment. But I think we've seen how that can be done to great patient benefit at the end of the day, which is the single most important thing. So thanks very much. Thanks to Creo for sponsoring this webinar, perhaps the first of many. We will see. Thank you very much, everybody.
Thank you, Brian. Thank you, Brian.
Bye.
Thank you.
Bye.
thank you very much, everyone. Thank you, Brian. Thank you, Creo, and all the attendees. Good evening.